We are now live on Facebook. So thank you for your patience, everyone. Welcome to today's Q&A with Professor David Jones. Thank you so much for being here.
Pleasure.
Everybody looks very much looks forward to this time with you. So thank you for this. Quite a few questions have come in. And just to say, you can join us in the privacy of Click Meeting. And if you're on Facebook, just to remember it is a public forum. Keep that in mind. So these are just little reminders. And remember, it's medical information in these sessions that Professor Jones is providing, and it's never in place of you reaching out to your healthcare team. But we do hope that with what he's got to say, it helps you get the most out of those consultations. So
I think that's a really important point, actually, that this is, if any of the information that we give helps you have a better and more informed conversation with your clinician, then that we've achieved what we're setting out to do. And going into your conversations with your clinician informed, being very clear what you need to get from those, you'll get the best quality from it. The better the questions you ask, the better the answers will be.
Yeah, absolutely. And just a little reminder that these sessions are all uploaded to PBC TV. So for those who can't tune in at this time, it doesn't suit, or if you're scribbling your notes and your pen's running out of ink or whatever it might be, you can go back and watch it. Okay, so we've got some pre-submitted, and just to remind people that they can do that as well. So here we go. I am AMA-M2 positive. My ALP is 140, Fiberscan score is 4.3, and I'm asymptomatic. And this person is saying they're having trouble understanding the rationale for starting treatment straight away. So I think this is a really good one. So they want to know, they've got the consultation with their consultant next week. So this is a great time to keep Cheryll on that, please.
Okay, so when I first started seeing people with PBC in 1991, so I've seen this whole thing unfold over a very long period of time. And what we saw in those days is completely and utterly different to what we see today. So when I first did PBC clinics, half of all patients were jaundiced. Half of all patients were jaundiced. The average numbers of fractures that a PBC patient had was 9. And those are unrecognizable things that, compared to what we see today, where PBC is, for most people, a very mild condition that is easy to treat. For a number of people, the symptoms can be a problem, and we need to have better options for all of that. But it just isn't the problem that it used to be, provided it's diagnosed and treated appropriately. Now, when it gets very interesting is that I can't tell you what made the difference, okay? Because we've been mulling about this in the field recently, is of all of those things, what was it that made a difference? Why do we see something totally different to what we see today? And the answer, I think, is all of it, actually. I don't think there is an answer to PBC. There are lots of things that have been part of the answer. And an integral part of that answer, the thing that's been in use for the longest period of time, is ursodeoxycholic acid, URSO. That was the first treatment. It's the one that's been used in most people for the longest period of time. I don't think there's any doubt whatsoever on that basis that URSO has really changed the natural history of PBC. When we first in the UK started using URSO, we only used it in people with stage 4 disease or cirrhosis, okay? And we now know that was totally illogical, because actually it's a drug that works better in the earliest stages of the disease and then continued thereafter. So actually, if you want to get the best effect from URSO, you give it as early as you can in the disease, because the biggest wins in terms of slowing progression are where it happens early in the disease process, okay? So personally, having watched this over a long period of time, I think the new therapies like obeticholic acid and bezafibrate and some of the trial drugs are a big step forward. But I think the bedrock of treatment has been ursodeoxycholic acid and awareness about the disease and the importance of it all. So that's the backstory, is that what we do works in a way, you don't need a study to tell you the difference in PBC. You just need to be in the same clinic for 30 years. So for somebody who's AMA positive and with an ALP FOS of 140, first things first, that's definitely PBC. We would no longer do a biopsy in anybody. Everyone's relieved to hear. Lots of cheering in the background. So there are three things that you make a diagnosis of PBC with. One is anti-mitochondrial antibody, or AMA, or M2. They're all the same thing. The second is the liver blood tests, particularly the alkaline phosphatase being up. And the third is a biopsy. 2 out of those 3 equals probable PBC. And we diagnose all people with PBC at probable level. We almost never do biopsies anymore. So in that sense, this is absolutely typical of what we would recognize as a standard PBC diagnosis in 2023. Don't need any more tests, it's PBC. Now, 2 things that follow on from that. What does a Fiberscan of 4.3 equal? Really good. Okay, that's really, really good. And that's really, really good news. So the one thing you never know if you've just been diagnosed with PBC is how long has this been grumbling away? Okay, somebody might have done a test today because there was a particular reason to do it, because you went to a well woman clinic or something like that. But that doesn't mean it wasn't there 10 years ago and just wasn't being picked up. So Fiberscan looks backwards as to how much injury has happened in the past. And to have a Fiberscan of 4.3 equals no injury in the past, no scarring, no question of cirrhosis. And that's really good news, because if you properly treat the condition in that situation, then this is going to be absolutely sortable. Okay, so that's really good, a Fiberscan of 4.3. Asymptomatic is really good because, unfortunately, you can have early disease and you can have pretty mild liver biochemistry, but still get a lot of symptoms. If you don't have symptoms at the beginning, you tend not to get them later on, so it tends to run like that. So that's another bit of good news. Lots of good news here. And then when you look at the alkaline phosphatase, 140 is only a little bit elevated, but it is elevated. Okay, now the upper limit of normal is 130. Okay, and you're 140, so that's a little bit under 10% elevated. Okay, PBC patients can get values of 2, 3, 4, 500. Okay, so it's low for PBC. We know from lots and lots of research done by lots and lots of people that the higher the alkaline phosphatase, the more the risk of the disease progressing. But that's over a large group of people. So if you have 1,000 people, then, you know, on average, the higher the alkaline phosphatase, the more aggressive the disease is. But I've seen people with normal liver biochemistry who've got cirrhosis. So when you get it down to the individual, you can't be quite as certain as that, because averages, you know, tell you about whole population, but it's you that you're interested in. So generally speaking, a lower alkaline phosphatase indicates lower risk of going on to get fibrosis in the future. So what would happen if you don't take treatment? Probably this would remain fine over time, and it would, you know, may progress a little bit, and it may grumble on. And, you know, in a lot of ways, whether that's okay or not depends on age and other things that are going on. So if you're 30 and you want 50 years out of your liver, that grumbling over time may be a big issue. Okay, and that's important to be aware of. If you're 90, less important. Okay, so just a context of all of that. What I would say is that urso is completely safe. Okay, it has no significant side effects. For the vast majority of people, it's easy to take. So my question would be, why not take it? Given my experience since 1991, it's the bedrock of it just being a different disease. So I would slightly flip the question around. I would be really pleased the Fiberscan's good, really pleased you got no symptoms, really pleased that the alkaline phosphatase is a little bit elevated, but why not take treatment, make your liver blood test normal, and then genuinely forget about it? So how badly do you not want the treatment when that treatment is very safe in side effects? And I think for that reason, our mantra is urso universally. However, if you decided not to take it or wait and see for a year or two, it's not an illogical thing. It's not what I would do. It's not what I would recommend, but it's not a daft thing to do. And a lot of people do that. The only caveat with that is somebody needs to be watching your liver blood tests. And we do know that this is one of the areas that it does fall down with the GP. So my suggestion is get your blood test done every year if you decide not to have treatment, and make sure you know the values. And if that alkaline phosphatase is going up, then your body has reached the answer for you. So I would treat in this situation. Why not continue with the good news story? Because it's not like steroids or, you know, drugs with serious side effects. It's a very straightforward treatment.
Super, thank you for that. I think going into the consultation then next week with that view in mind, Yeah, really great. Thank you so
Cheryl
much.
is now facing the horror of having to go to quick fire round and keeping me under control.
Wish me luck, folks.
Quick fire
Wish
round, for
me
those of you who haven't
luck.
joined this before, it's a battle of wills between normally Robert, Colette as was in the past, Robert and
Yes.
Mo, now Cheryl,
Yes.
versus my inability to give a short answer.
But a great answer it was, so thank you so much. And of benefit, even somebody's popped up on Facebook and just think have said it's reassuring to them as well. So yes, an important one. Another one on that theme of Urso, this person has said, this is a different patient. I was put on Urso mid-June of this year, 1,200 milligrams. You've got a bit, I'll go into the question more. Are fluctuations normal during the first year of Urso? Is the question. And because theirs has went in a downward trend of late, how concerned should they be that it suddenly jumped after being, it's went in an upward trend after being on a downward trend? Apologies. Yeah.
Okay. So Urso takes a long time to get into the system. Okay. So we all know if you have a headache, you take a paracetamol and it works within 15 minutes. Okay. Urso has to get into the bile pool. And so actually it takes several months to reach its maximum effectiveness. So, because bile acids get into the body and then recycle. So this is one of the reasons why if you go away on holiday for a week and you forget your Urso, you don't need to go emergency prescription. At the end of that week, you're going to have 95% of the Urso in your body that you had at the beginning of the week. So it's not a treatment that has to be painstakingly taken, and you get problems if you don't. So fluctuations therefore can happen because the body is bedding down. So it's this sort of getting used to it and bedding it down. PBC, the alkaline phosphatase, tends not to fluctuate that much. It's a disease where it doesn't tend to fluctuate. That's been very helpful for a lot of the clinical trials that we've done, because you can predict what's a real effect from what's noise. It slightly depends on the degrees of the fluctuations and what the sorts of levels are. So if it's in that range between about 130 and 200, it's bedding down. I think if the ranges of values are getting slightly greater, then it just needs a little bit of thought, because it's not a typical PBC thing. Okay. The thing to watch out for,
114 to 144 for this patient.
It's from
114 to 144.
Oh, you don't need to be worried about that at all. That's just noise. Okay, that's just noise. If it's going to 300, then that's potentially more significant. So that's just the body bedding down, and that's ranging from normal to slightly abnormal, and it will settle out at the range that it's going to. If there were more, I think it's just a useful point. If there were going to be more fluctuations, if it was going up to 300 and down again, that's classic for gallstone problems in PBC. And gallstones used to be very common in PBC. They're not so because of Urso's beneficial effects. But one of the reasons why people used to get fluctuations is problems with gallstones getting out into the bile duct. So if I saw somebody with PBC with big fluctuations in alkaline phosphatase, first thing I would do is repeat an ultrasound scan and just make sure there isn't any mischief about gallstones. So, but other than that, it tends to be pretty consistent. And of course, remember, Urso dissolves gallstones very slowly. So just when you first start it, you can convert a stone that can't get out of the gallbladder into one that can, and get into the bile ducts. If you're ever going to get gallstone problems, it's usually in the first year of Urso where they've been loosened up a little bit. That is not a reason to not take Urso. Those problems are very rare, but it's just worth being aware of. So a scan is always quite useful in those. We do lots of ultrasound scans, non-invasive, very safe, and it gives us a lot of information that's usually reassuring.
Yeah, I'm just reading this person's been feeling quite stressed over these results. This
no
4 to 144. So
no.
Take a breath and
yeah. No. Those are really good. Remember, the magic number is 200. Okay, where the goal of treatment is alk phos below 200. Okay, the lower the better, absolutely. But I will be telling you in the clinic 144. That's really, really good. Okay. Remember that the rate, and doctors are not very good at this. When we, the audit, the foundation and lots of people have been involved, an audit of practice in PBC. quite depressing in the sense of how bad most doctors are. I'm guessing I'm talking to an audience who know this, how bad most doctors are at talking about this and explaining what these values mean. And what constitutes a significant abnormality in a blood test depends on the blood test. Okay, so there are some blood tests. So an ALT, for example, alanine transaminase, that's one of the other liver blood tests. The upper limit of normal is 45. Okay, some PBC patients have a value up to around 60. Okay, something like that, and people can be worried about that. ALT you get with viral hepatitis or with glandular fever or things like that. A significant level would be 10,000. Okay, so it's exponential. It's a log scale. So 45 to 60 is not that significant when up to 40,000, is the sorts of values you can see. And that's for us to explain to people, but we're not very good at it. But I think it's an important point. So those sorts of fluctuations are just noise. One of the things we sometimes do with young doctors, just to make a point, is to take a blood sample, split it into 4, and send all 4 of the same bits of the blood sample to the lab and look at the results that come back. And what you'll find is variation between them. That's just the machine varies in the values, not 114 to 140, but 114 to 120, 114 between 110 and 120 with a mean of 114 is just an error in the machine and the tests. Okay, so you've got to remember that these, although it sounds like an exact number, these machines are not infallible, and that's why you always take the big picture with these. That's why we do panels of tests, because we're looking for different things that point in the same direction. So that's why single one-off blood tests you never want to ascribe too much significance to. You need to look at the whole picture.
Again, so reassuring.
But if you are worried about those tests, don't be worried about those tests.
And this is why these sessions are so important, because knowledge is power. And like you're saying, for speaking to your clinician. And this next question kind of follows on a bit from that, and it's how do I approach healthcare when I feel that my GP is missing key treatments? So I know the recommendation of a Fiberscan every 6 months. Yet it's been a year since my last one, and my GP shows no intentions of ordering one, and they're frustrated. So any hints, tips, any advice from you would be greatly appreciated on how to approach this.
Okay. Well, the first bit may surprise you, which is don't have a Fiberscan done every 6 months. Okay. So Fiberscan is like all of these things. I always say to people, on Star Trek, they used to have a machine that they would bones would point at people, and those people of a certain age like me would know what I'm talking about, which would tell people the diagnosis. And wouldn't it be brilliant if we had that? We don't have that. So what we have are tests that give us a bit of information, and we build up pictures with all those bits of information, but we always remember the fact that these are not infallible tests. Okay, so Fiberscan we use to look for the presence of fibrosis and ultimately cirrhosis. However, it does not do what Bones's scanner does. It doesn't tell you whether somebody has cirrhosis or not. It tells you how dense the liver is at that particular moment on that particular day. And there are lots of reasons why the liver may appear more or less dense. Again, 1,000 people, over an average of 1,000 people, it will predict the amount of fibrosis, but for each individual person, it is less likely to do it. Now, I'll just go off topic a little bit here. So anybody who's watches football will be aware of Newcastle United. And the classic fat Geordies who take their shirts off and stand in the crowd. It's well known. There's a meme on television. Okay. Now, if you were to take an average of all the people in the 50,000 going to watch Newcastle, then that would be representative of a particular type of people, and you'd measure that's 10% of people that are like that. Okay. If you've got a helicopter to pluck one person out the crowd, it could be somebody who looks like that, in which case it would be typical, but it could be a grandmother taking her grandson for a birthday treat to watch the football. That does not mean that everybody going to see Newcastle is a grandmother. Okay, it means that you have picked one out of a large group, but that one is not representative of the larger group. That's the point about individual values versus a whole population. Are you the fat Geordie without a shirt on, or are you the grandmother that's happened to be picked? Okay, so it's about the extent to which any group is representative of one individual. Another way of looking at it is the average number of legs in this country in people is 1.9, because there are most people have two, and a small number of people have one or no legs. That does not mean there are any people with 1.9 legs. Okay, so it's just that way of thinking about it. So the problem with Fiberscan is that it clinically measures something that will only change very slowly. Okay, so if we're measuring fibrosis happens over years to decades. Okay, Fiberscan, however, errors of fluctuation to do with what you ate that day, or how much venous return you've got, and have you been on a long journey, are you dehydrated, all of those things, those happen every time you do the scan. So long-term trends will be picked up over time, but errors will happen randomly. So the more scans you do, the more likely any individual value is to be wrong. Okay, because it will give you more chances to have one of these unpredictable things. Okay, so I would never Fiberscan people every 6 months, never, because you're going to get errors. Now, if you had a value, did a Fiberscan, had a value that didn't make sense in terms of, we talked about that picture. So that taking everything together picture. If I got a Fiberscan value that didn't fit with the picture, then I would repeat the Fiberscan. I would get it done by a different person, a different day, just to take away that individual variability to it. And that will be a very valuable thing to do. But don't do it every 6 months, because you're just inviting errors. A bit like bone density measurements, that don't measure those more frequently than the bone can reasonably be expected to change. So I wouldn't go and badger the GP about a 6-monthly Fiberscan, because I don't think that's the right thing to do. It's really important to have a Fiberscan, every couple of years. If you can get one done every year, that's useful, but always have a caveat about it all. So I think it's about a relationship with the GPs about what is standard treatment without going too far with it. So I think what's reasonable with PBC is you get bloods checked every year, that you have URSO as a first-line treatment, you have awareness taken of your symptoms and an appropriate onward discussion, organising for a Fiberscan every 1 to 2 years, bone density every sort of 3 years or so is a basic package. And that if things fall outside kind of normal with those things, then those things are acted on. But Fiberscan every 6 months is going to give anxiety, because it implies there's going to be a change when there won't be. Clearly that we do have people who we Fiberscan more frequently than that, but those are people who are in a particular very narrow band who seem to have progressive disease. So as much as is possible, kind of work with the GPs and get to go and see a clinician that you feel comfortable with. Generally speaking, most people with PBC benefit from seeing a specialist of some sort or another. It does depend on local provision. The reason being is the average GP would look after 2 people with PBC in their career, and therefore it's not reasonable for them to know current thinking. I can obsess about current thinking for PBC all day long, but that's all I do. And so therefore, I don't have to look after all the things that the GPs look after. And I think that's where most GPs, to be honest, so the foundation does produce literature, that can be given to the GPs, and a good doctor would value that, because the knowledge base within the PBC Foundation is vastly larger than their knowledge base is going to be about PBC. And a sensible GP would realise that. And so if there is easy, good guidance based on the international consensus in the field as to what to do. A good GP will say, thank you very much, that's really helpful. Are we doing all of this? And you'll say yes, and he'll say great. She'll say great. Or if not, what you can say is actually, what the foundation says is that, we should get Fiberscan every year and a bone density. And I think a good GP will say, great, that's actually really, really helpful. A bad GP will feel offended that you've suggested they don't know what they're doing, but they've identified themselves as a bad GP. And I think, Cheryl, your thought on that from a nudging GPs to do the right thing, it's a really key question, isn't it?
Absolutely. I think what's really important to remember, you've got the foundation supporting you. As Professor Jones says, there's the resources, we've got information that then can really help you feel empowered, help you feel prepared to go into that consultation. Those can be downloaded from the website or contact the office to get hold of those. I'm thinking EASL guidelines, all of these things, so knowledge being power, accessing the services. And so we go in there, and I think that key word that you mentioned was relationship with the GP.
Yeah.
And it's building on that, it's asking questions, it's listening to their response, but also knowing what they're the things you need. So 6 months, but that's unrealistic, but asking what is realistic, what should be having, is it a year, is it 2 years? If there's another question I've got from somebody else in relation to Fiberscan, if you've been told your local hospital doesn't have the machine, what next? If you've been told, we don't have that, what suggestions there of what to do?
Yeah, so these are really good questions. It never ever ceases to amaze me that years down the line with all of this, we get new and different questions. And it's just, which I think are very useful to inform the way to think about all of this. Fiberscan, I'll be getting a little bit controversial here. And I say Fiberscan is nice to have, not must have. Okay. So we have Fiberscan in the clinic. I'm in a very lucky position. We have it. Our nurses are trained with it. We can bob people down the corridor to get the Fiberscan there and then in real time. Okay. And actually, that's very useful because it adds value to the consultation. Most people we Fiberscan, we expect and find the answer to be a very low risk thing. And actually, that's probably the most important use of Fiberscan in my experience. Is that it's really reassuring for people. And that I tell people, look, I'm not worried about this. It's really great, but let's just do a Fiberscan. And then he come back with a Fiberscan number. He said, look, that's what we said. Look at that. That's really brilliant. So I'm not surprised, but isn't that great? And that really helps people take away the anxiety. Yeah. Now, I managed people with PBC for a long, long time before Fiberscan was available. And actually, wise clinicians can understand the fibrosis risk in people without Fiberscan. It's nice to have, but it's not infallible. And, we existed just fine without it. In fact, there are other blood tests that are very useful. So the one that we use all the time is platelet count. Okay, so platelets are one of the cells in your blood. They're the little cells that clot the blood, but they tend to sit in the spleen. If the spleen grows, if you've got cirrhosis, you get increase in the blood pressure in the portal vein, the vein that drains from the gut to the liver. Your spleen grows and the platelets sit there. So actually a platelet count below 150 is as accurate as Fiberscan for predicting the risk of advanced fibrosis. And that's the tool that we use all the time. So I check everybody's platelet counts all the time. It's part of the standard set of blood tests all doctors do all the time. But there's a lot of information you can get from very small things. So I think where I think it gets very important is Fiberscan is useful. It's useful as a one-off in people presenting for the first time who are very low risk because it makes you absolutely confident and allows you to reassure people. Okay. So that's a real use of it. Fiberscan is not useful in people who've obviously got cirrhosis. Okay, so if you've had a varicose bleed, very uncommon, but it happens. Fiberscan doesn't tell you anything at all because the varicose bleed trumps it. It tells you there's a problem. All Fiberscan does is what's the likelihood of you having a varicose bleed? Well, having had a varicose bleed, it's sort of asked and answered. So strangely, the people everyone think it's useful in, it's not that useful because it just adds extra information. If the Fiberscan appears low, well, you still have a varicose bleed, and if it's very high, well, you're not surprised at all. Where it's useful is in the middle, where you've got a value of 10, 11, 12, 13, because increasingly there's going to be a real focus on people in that category. And at the moment, we make treatment decisions for second line therapy, obeticholic acid, bezafibrate, on the ALK phos values. But increasingly, I think we're going to factor those Fiberscan values in. And I think I would be keener to get more effective therapy on board somebody whose ALK phos was okay if their Fiberscan was in that range than if it was in the 4, 5 or 6 range. So there will be a point where it's particularly useful. But I mean, if you've got that type of disease, you should be being looked after in a hospital with Fiberscan, because if you haven't got Fiberscan, they're not really a liver managing centre. So it's probably at the point where you need to move. But for most people, it's nice to have rather than must have. Remember, and this is really important, it is not infallible. Okay. In these meetings, I have told this story before. A very nice young patient, she was a nurse in my hospital, who had an AMA and very slightly abnormal liver function tests. And she used to pop in every year to see how things were going. We'd have a bit of a chat, and it was all very good and reassuring. And then she saw the registrar, who was new and full of exciting knowledge about exciting tests. Okay. Mm-hmm. And she ordered a Fiberscan, and that Fiberscan was in the cirrhosis range. Okay. Now, if I'd seen that patient in that situation, I'd have thought, hang on a second, there's a rabbit off here. This isn't fit with everything else. This just doesn't fit. This is a rogue result. Okay. Don't know why it's happened, but it's a rogue result. And I would have rechecked it. Okay. On a different day with a different person. My colleague organized a liver biopsy. Okay. The patient had a significant bleed from that liver biopsy. Okay. And did well to, not have a really bad outcome with it. The biopsy was completely normal. Didn't even have PBC, even though she was AMA positive, slightly with LFTs. No evidence of any fibrosis. And when the Fiberscan was repeated after that, it was in fact 5. Okay. Now, I wasn't there on that day. I don't know why a value of 28 or whatever came out. I can't explain it, other than it's a human investigation without a hard record. If you have a CT scan, okay, it's on a computer till the end of time. And if it doesn't make sense, you can go back and look at it, and you can decide, look at it again in the light of things that change. But a Fiberscan, it's just a number that comes out and is written down on a piece of paper, and you can't go back and cross-check it. So that's not to say my colleagues can't do Fiberscans. They can. Anybody who does Fiberscans will tell you these rogue results come out. And what you then do is just take a step back and realize it's part of the picture. It's not the whole picture. And, so it's a really useful thing to have. I don't, we're not going to give our Fiberscan away. It's really useful, but it just has these caveats. So that's not to say don't have a Fiberscan, but it's don't just have a sort of headlong rush into responding in a particular way. Take a step back and look at the big picture.
Yeah, a really, really full but really helpful answer. And I just to remind people on Facebook, somebody's asking, will this be available later because they can't hang about? Absolutely, we will upload this to PBC TV so that you can take your time, because that, again, just that one answer itself, I think, just offers so much information. So thank you so much. I'm just looking at Facebook to see what's live in the room just now, what's coming up for people while they're listening. So if you don't mind, there's one saying, I don't know the age of this patient. If they're around, they can let us know, but I'm not old enough to get the current COVID booster. Do I qualify as a PBC patient, or even should I have the jab? They're asking. I've had COVID badly pre-vaccines and had boosters when eligible. Anything to say on that?
Yeah, so there's a lot of COVID around at the moment. There's a lot of COVID around, so just people be aware of that. We started, for those of you who don't know the history of this, we started the Q&A sessions as part of the keeping engaged with everybody during COVID. And I think absolute hats off to the PBC Foundation, for their efforts around both these, but also the kind of, link up sessions and, I hear again and again and again how people felt very isolated during all of this, and actually it was a place they could go. And so absolute and utter credit to the foundation. We also learned something about how valuable these digital things are, in addition to face-to-face stuff. So I think it's one of the things that I don't think we'll ever go back to a world where we don't do these sorts of things. And I think the numbers, last time I spoke to Robert, the numbers of people who've engaged through all these various different things is just extraordinary. It's
Incredible.
hundreds of thousands of people. It's just extraordinary. So COVID. So over the years, we've had lots of talk about COVID. We've had lots of talk about vaccines and things like that. And we've been over ground. So I'll say something standard about the COVID vaccines, and I'm not I'm an immunologist. I'm not a zealot about those vaccines. But one of the things I said all the way through COVID, and I'll say again, is that there are two things in human health that transformed beyond anything else. One was access to clean water, and the other was vaccination. It's not antibiotics or statins or surgical procedures. Those are the two things that help the population at a population level. So vaccination is one of the things that makes our world safe in general. Okay. Now, those of you who are, watch the news will know there's a lot of controversy again about the AstraZeneca vaccine. None of that, I don't think, is a surprise to us. This was stopped being used by most people very early on. And it does show that vaccines stimulate the immune system. That's how they work. But on balance, goes back to my 1,000 people, on balance, they clearly benefited people. They did not stop people getting COVID. They did not stop people feeling rotten with COVID, but they stopped people dying from COVID. Okay. So they had a slightly different action to, prevention, which is what people tend to think about them. Now, PBC and COVID is a really interesting and complicated story, because something very interesting occurred to lots of people is that throughout the first and second waves, we just didn't see the problems that we expected to see. So people with a chronic illness, people with liver disease were thought of as being high risk. But hang on a second. And yes, there were people, who did it. It's back to my 1,000 versus a 1. But on average, we saw far fewer people than we expected we would do, and far fewer people than, for example, the autoimmune hepatitis clinics or the viral hepatitis clinics who did see problems. We just didn't see many. We were very interested by that. Now, on one level, it's PBC patients tend to look after themselves. You're all here because you pay attention and are keen to do the best you can. So one of the joys of helping PBC patients is they help themselves. So do look after themselves, do take advice, do the sensible things. So that will be an element of it. People kind of looked after themselves, but it still seemed to be more than that. And we wondered if it was to do with maybe the genetics that gave rise to PBC, but quite bizarrely, it's urso. Okay, so it's now been established that ursodeoxycholic, including in information from UK PBC, the Cambridge genetic study that many, if not most of you will be involved with, that ursodeoxycholic acid, our old friend urso, reduces the likelihood of the virus being able to infect people in a way that is harmful. So it blocks uptake of the virus. So that means even if you do get the virus in the body, it's a lower level, which means you get less harm. It's urso. By an unexpected novel mechanism of urso. It's a complete chance observation, but it's true to the extent that there are some people who just don't respond to vaccines. So the big group that need to be worried with COVID are people with blood cancers, leukemias and things, lymphomas, because they don't mount a proper immune response, and therefore they don't get vaccinated effectively. The vaccine's safe, but it just doesn't really work. People are now giving them urso. Can you believe that? They're giving them urso to reduce their risk of getting COVID. It's a brilliant story. So what do I think? I think if you're on urso, don't stop it. And maybe going back to our should I take therapy, that's another tiny reason to take urso as well. The mainstay of making COVID not a problem in PBC is vaccines, as it will be with everybody else. And so my general advice would be to get boosters because it goes back to, as I say, my 1,000 versus 1. So generally speaking, I would regard anybody with PBC as as having chronic disease and therefore justifying getting a vaccine. But again, if somebody turned around and said, look, I've not had problems with it, and then it's not an illogical thing to do. But generally speaking, I think the conventional wisdom is that there is a risk with any chronic disease is reasonable, and I would have the boosters. But it's not a crazy thing not to do it. So I would play the PBC card and argue that you're in a risk group and should have access to the vaccine if you wanted it. Okay, just generally speaking, out of interest, if you look at most clinicians got vaccinated. We were exposed to COVID doing what we did. Most people have not followed up with long-term boosters. Okay, and whatever that tells you, it tells you something. Is that not sure that endlessly repeat boosting is not actually necessary, because low levels of COVID themselves boost your immunity. So the way it's settled out is that people are getting repeat episodes of not too bad COVID, and that probably naturally boosts their immunity. But that I'm not an expert on it, but I think COVID vaccines made a big difference. But I do think PBC patients, with the exception of post-transplant people and people on immunosuppression, so a very small number of people on MMF and things like that, we just didn't see the problems that we anticipated, and it was Ursa.
Wow, I do hope that's helpful. I see the person's in and around, so let us know that's been helpful for you. We've got somebody here in Facebook saying hello from Australia, newly diagnosed. And
Hello.
Hello there, and have cirrhosis early stage, and asked their hepatologist if they could take, now my pronunciation might not be quite right, Ozempic to help with weight loss. I've never heard of that. He said it was fine, but my local doctor won't prescribe it, as he says it's not safe with PBC. Your thoughts on this one, please, Professor Jones?
So, hello in Australia. I was out in Australia earlier this year as the new drugs are being made available, so doing some educational tours, and it did allow this will mean absolutely nothing to most people on the call, but it will mean something to the Australian people, which is it causes endless amusement, my name, to people in Australia, because the equivalent of Woolworths, or Harrods or in Australia is called David Jones. So when they hear my name, all Australian people laugh at my name, because it's like being called Mr. Woolworth. So I had that opportunity, to amuse lots of Australians. Something that literally nobody knows, because I only spoke to Robert about it this morning, yesterday morning, is that the PBC Foundation, the clinicians and hepatologists and patients in Australia are very keen to build their PBC kind of community. I think there's a realization that it's not perhaps been at the same level as it maybe has been in the UK, for example. And they've reached out to me about what I thought about developing a sort of PBC groups in Australia. And in particular, would the foundation be interested in working with people in Australia to develop it? And we all think it's a brilliant idea. So to just set up a kind of a branch of the PBC Foundation Australia. So watch this space. I think
Wow.
don't reinvent the wheel. Build up, particularly where language, obviously language around the support materials and everything else like that. So there's a real move, and there's a real passion from the Australian doctors to kind of improve what they do. They realise that they're not quite doing, and maybe people like me going, well, talk about what we do kind of helps make them think, maybe we can tighten up a little bit on all of this. So watch this space in Australia. And that's why I've offered to, go down there for a month or two, particularly in the months of sort of December and November, if they need any helping out with that, I'd be open to that. Nice hotel, couple of months in the summer in Australia. I'd be happy with that. Right, cirrhosis. So Ozempic and cirrhosis. So there is no data on PBC and Ozempic and Wegovy, these drugs, right? So there is no data. So nobody can say if they're safe or if they're unsafe, okay? Because there just isn't any information, largely, I think, because they haven't been widely used. the guidance for it, I think, because I've been asked this question by one of my patients, and so what I said is there's no upfront reason not to take it. However, they then couldn't get it prescribed because the prescriber turned around and say there isn't evidence of safety. Now, that becomes very difficult. If you never use a drug in a particular situation, you can't know whether it's safe. And if you can't use it because you don't know it's safe, you can't use it, you never know it's safe, right? So there is a kind of self-fulfilling prophecy about all of that, which is problematic. What do I think? I think there's a general comment about these drugs and there's a specific one. I think anybody with cirrhosis, I would just be a little bit cautious with any drug because how the body handles things may be different. And so there's a little bit of a voyage into the unknown. So it isn't a case simply of whether it's cirrhosis or not. It's about liver function and things like that. So it's not a no, but it's a just check, carefully about your own individual values with the doctor about it. But anyone who says definitely yes and anyone who says definitely no is not correct, because we definitely don't know. Okay. The other thing is just an observation in general about these drugs, which is that they're really good for the scales. Okay, they're really good for the scales, but they're less good for you. Okay, so you do lose a lot of weight with these drugs. That's true, and there is a risk of pancreatitis and pancreatic problems with them. That's very rare. That's also true and well signposted. What is less well signposted is the fact that the weight that you lose is predominantly muscle, not fat. Okay, so Mr. Kilogram goes down, but if you lose 20 kilograms, if 15 of that is muscle, and exercise is an important part of this, that's a little bit of a false economy if you think about it. So they make you lose weight, but they slightly overemphasize losing the wrong sort of weight. So for people just to be aware of that, and there's a bit of naivety about how they're used, just look at the scales, look at BMI, but actually looking at muscle mass is a very important thing, because actually as a way to get going. So I think if I were to take one of these drugs, I would use it as a way to get from where I started to where I wanted to go, which is able to exercise more and feel healthier. But I would not regard them as a long-term. They are a means to an end, not an end in their own right. I think there's a lot of data that when people take them for a long period of time and they stop them, the weight just goes back on. And that's largely not because people are eating too much fatty food. It's because they're putting the muscle back on because the body is sensing that loss in muscle mass. So they are not the magic answer, I'm afraid, that people sometimes think they are. So just think cautiously about them. I don't have a problem with PBC. I think the caution about liver disease is to do with not knowing rather than it being a specific thing. But there's always a little bit of a caution for any drug with cirrhosis.
Okay, right. We're definitely at the quick fire round point of the session, and I'm just looking and seeing what could be quick fire. I don't know how good I'm going to be at this, but we can try.
Robert's famous for this. He'll do quick fire round. He'll say, right, last question. You've got 30 seconds. What's the meaning of life?
Oh, right. Right, it would be quite that, but let's see. I know you need to go in 6 minutes, and we've got maximum. So here we go. Somebody on Facebook, diagnosed 4 years ago, responded to Ursel well, ALP reduced from 200 to 130 until July this year. That was still on Ursel, but ALP continues to say just above 200. Had ultrasound, gallbladder is fine, Fiberscan 5.4. Now waiting for Edinburgh referral to get second line prescription, as in my hospital they don't do second line approval. Concerns are waiting time for the right meds, and what if they also fail at some point?
Okay, so in that situation, definitely second line therapy. There is a system in the UK for how you get second line therapy, so it's not a lack of knowledge at your local hospital, it's NHS England rules. But that's been in everyone's benefit because it means that sensible decisions have been made about second line therapy. There are two options, obeticholic acid and bezafibrate. The presumption is people go on to obeticholic acid. The reason for not doing that is if they've got particular problems with itch. These drugs are both very effective, and with an alkaline phosphatase just above 200, then you will undoubtedly get a good effect with either of those drugs. There isn't a desperate hurry in those values. It's not going to go terribly if you don't, but sooner rather than later. What happens if it doesn't work in you? Well, that's pretty unusual. Almost everybody gets some benefit from them, and the degree. If the benefit isn't what you want to see, 2 years ago they'd swap you onto the other. If it was beta fibrate, go on to obeticholic acid and vice versa. In 2023, it's very clear cut. You go on to the third one. So we do combination therapy, and this is something we'll end up talking about lots and lots and lots in these sessions, because total normalization of all blood tests happens in about 60% of people on third line treatment who haven't responded to urso. So we're not talking about improvement with this, it's normalization of everything. So they basically have busted the field open, this use of triple therapy. And that is going to be all of the talk. And the single commonest regime over and above just starting urso as first line, the commonest thing we do in our clinical service is put people on triple therapy. Okay. So, but you don't have to go on that from the beginning. We normally do it as an additional thing. First, obeticholic acid, then review how it's doing. If your blood tests normalize and just obeticholic acid, that's fine. But if they don't, then I would add in the third one. They do seem to all boost each other.
Okay. I am taking 3 times 250 milligrams of urso, but in the last 5 days, I've started feeling pain in the liver, like a burning sensation. Never had this discomfort before in this area. Is this normal, and will it go away with time?
Yeah, so you get pain in the liver as part of PBC. It's one of the symptoms that everyone forgets about. A dull ache, it comes and goes. So it usually gets better with urso, but it still comes and goes. Remember what I said about urso loosening gallstones and gallstones being a feature of PBC? So that's always in the back of our minds. So if people have new pain in their liver, then that's where we would always do an ultrasound scan, because it's kind of an occupational hazard of being a PBC patient, is gallstone and gallstone related disease. If there isn't a blockage and a significant stone, then it will settle down. But it's worth just doing it, and we do not infrequently send people with PBC for gallstone surgery. Okay. Important to remember that the liver, there are a number of organs that overlie. So you've got your liver and gallbladder, but you've also got the pancreas, you've got the stomach, you've got the colon, and not far away you've got the kidney. Okay, so it is important to remember that just because you've got pain around the liver, it's not automatic. It is the liver, but again, a good clinician will be able to work out from the nature of the pain and things like that and the examination. So, but pretty much all of those things we picked up with an ultrasound scan, which is one of the reasons why it's the first line. The one thing that isn't picked up particularly is good old-fashioned stomach and duodenal ulcers, which can sometimes present with pain like that. But there's a well worked up pathway for looking at those things. So I suspect it's just the PBC pain coming and going, but probably an ultrasound scan is useful. Let's do one more question.
Ooh, one more. So there's something popped up on, I don't know how quick you can answer this one, but somebody's commenting on Facebook. There is thought that fenofibrate, while helping liver enzymes to go down, is just masking the numbers and giving a false sense of security. Any thoughts on that? To be the last one of the day.
This is Robert's famous, what's the meaning of life?
Yeah, I follow in his footsteps quite nicely.
That's a really important point about all of these drugs, okay? Just think about a different thing, okay? If you, one of the treatments we sometimes give to people is bottles of protein. So if people got ascites and things like that, we give them infusions of protein, albumin, okay? Now, albumin is a blood test that we use to assess liver disease severity. So the lower the albumin, the worse the liver disease. So it's a well-recognized test. It's a bit like bilirubin the other way around, right? So it's a useful test. Now, if I was to measure somebody's albumin and find it was low, give them 2 bottles of albumin and measure it again, their test has got better, but I don't think we'd think that their risks have been reduced. We haven't changed the disease. We've just made the numbers look a little bit different, okay? So changes in the number could be significant, or they could be not significant, okay? If somebody had a raised bilirubin and we gave them a treatment, the bilirubin normalized, that's almost always a significant thing. So blood tests can predict a change in the disease, or they can just be the numbers changing. And the closer a blood test is to the actual disease process, the more likely it is that that effect is a real one, right? So the blood test measurements we do with fenofibrate and obeticholic acid and bezafibrate are a little bit distant from the disease itself. So alkaline phosphatase is elevated in PBC. The more elevated it is, the more what we call cholestasis or poor bile flow there is. But that's not the same as saying that if you reduce that, you improve it. Is it like bilirubin or is it like albumin? Okay, so that is a caveat that's in the back of everybody's minds. Okay, now doing a trial of fenofibrate, for example, same is true all of the other ones, to an end point in a trial that really mattered, dying of PBC or needing a liver transplant, is going to take 10 or 15 years. And that's fine if you've got a reasonable thought that the drug works, but it's not fine if you're in the placebo arm in a trial. At the end of all of that, you find out what you should have had. So sometimes you're not going to be able to answer the question in the way you want to answer it. Okay. So yes, a trial that shows whether it really stops you dying or needing a transplant is perfect, but that's just not doable. It's not ethical, actually. So you have blood tests. Now, we as clinicians bear this in mind in terms of what we do. Okay, so we always factor this in. That's why we always look at the broad picture. That's why Fiberscan is useful, because it gives you something over and above just the blood tests. Okay, and remember what I said right at the beginning. Since 1991, something's changed. It's a different disease. Something's changed. So something we're doing is working. And so therefore, that's very strong evidence. So there is a thing called real world evidence, RWE, which is a thing that we're moving towards to actually collect the long-term experience of people in order to find out how treatments that people do and don't get, because that's the right thing for them, what then happens to those people. So a trial, if you like, without you being randomly put in a group or another, trial where you make the decision and we follow up what happens to people. And then you get your 1,000 and let's make it 10,000 people, you start to get real information. So at the moment, right now, there's a debate going on with people who license drugs about what that evidence would look like. That's what I was talking to Robert about, actually, we in the UK, you colleagues around the world, can play a major part in this. So it is very likely you're going to be asked to take part in a study where we simply watch what happens and record what happens to you in the way we would do in a trial. But when you get the treatment that you want to have, that you and your doctor have decided that you have. And what I've said to people, and I said to Robert, and Robert agreed with me, is I don't think there's any PBC patient who wouldn't be happy to take part in that. It's just collecting in a more formal way the information we routinely collect. Probably you think we do it anyway, but that your contribution to knowledge in PBC is to collect all the information we can on all the people that we can in a formal way. It's all anonymized. It's never to do with your name, because the name doesn't matter to this. It's what happens to you. And I said, so my argument is, let's mobilize the army of PBC patients who want this to be better for them and for other PBC patients. And let's get the people who regulate these things to tell us what they want, because they need to do that. And then we as a community will set that up, and we will collect information on everybody with PBC in a proper and formal way over the next X number of years. And I think people will be happy to do it. So we're finding a way through that is not, in a sense, individual experiences or a trial that we can't do. There is a comment about questions being asked. We always end up with more A, I talk too much, and B, we always end up with more questions that we can answer, but we get round to answering.
The nature of it, isn't it? It also says somebody's saying we always learn something new. Thank you very much, and we really appreciate these sessions. So thank you so much for your time today. And yeah, you're right, we didn't get through all the questions, but they will be carried forward to the next.
Just for those people who are new to this, there is a rotating cast of people who do this. We all have different views, okay? And so we all have different perspectives. I'm very much around holistic stuff, around empowerment, around symptoms and quality of life. There are other people who have a different focus on the disease. So it's well worth tuning into lots of different ones, because you get different perspectives and different international views. So it is quite useful to get the experiences of different people. But we do answer all of the questions to the best of our ability. And if only I shut up more, we could answer more. And I thought, Cheryll, I thought you were brilliant. Well done for stepping in at the last minute.
And Mo and Robert aren't hiding under the table. They're actually in Boston right now for the big ASLD Congress. So they're there. Are you managing to get there? Are you taking part?
I'm going on Saturday. I'm off for Saturday.
Have a great time and tell us all about it when you come back. So
I will do.
Robert will be back.
It's going to be one of those meetings. It goes in cycles. This is going to be a big meeting with a lot of progress. There's about to be a revolution in how we think of it. Now, you guys know all of this because we've been trailing the thinking. You're well ahead of the curve. So there's nothing that's going to be presented that hasn't been discussed in these sorts of meetings, things like triple therapy and all of those things. So quite rightly, you don't want to wait for it to go out to those meetings. That's what we're here to do, is to interpret and present all of that. But I think there's going to be a radical shake-up in PBC thinking, with more of a aim for normal tests, more of a focus on symptoms, hallelujah, and triple therapy. But I will.
Such good news. Thank you. Tell us more when you come back. Safe travels. Thank you, everyone.
Brilliant.
Thank you for your time
today.
Thank you,
everybody.
Bye.
Bye now.
For now.